So we begin with another topic, Lynch syndrome. So Lynch syndrome was first described by Aldred Wartin in 1939, and it was further delineated by Henry Lynch in 1966, after whom this condition is named. Lynch syndrome is an autosomal dominant condition closely associated with colorectal, endometrial and ovarian cancer. Okay, so at least these three cancers you should remember, but there are many other cancers apart from these three cancers. They are seen in patients with Lynch syndrome. Okay, and this is an autosomal dominant condition. Okay, so women with Lynch syndrome are at increased risk of both endometrial as well as ovarian cancer, and they should be offered personalized counseling regarding family planning and red flag symptoms and risk reducing strategies. So once you know that this patient belongs to Lynch syndrome or is a case of Lynch syndrome, in that particular case you have to offer them counseling regarding family planning. So they should complete their family quite early. Then you have to suggest them what are the red flag symptoms for endometrial cancer, ovarian cancer and other cancers, okay, which are seen in patients with Lynch syndrome, and you have to suggest them risk reducing strategies, and what are those strategies we will see in subsequent slides. So early identification of Lynch syndrome can enable the uptake of cancer risk reducing strategies, including taking the aspirin and lifestyle modification. And what is the evidence for this, that we will be seeing in the subsequent slides. Okay, so gynecological cancer is often the first cancer diagnosis in women with Lynch syndrome. Testing strategies involve risk stratification of cancers based on phenotypical features, and definitive is a germ line testing is the definitive. Okay, so Lynch syndrome arises from inherited mutations in the genes encoding for proteins of the highly conserved DNA mismatch repair system. Okay, so there is a genetic mutation involving the genes which are related to the DNA mismatch repair system. Okay, so what are those genes? They are mut L homolog 1, that is MLH1. Then second is a mut S homolog 2, that is MSH2. Another is a mut S homolog 6, that is MSH6, and PMS1 homolog 2, that is PMS2. So these are the gene pathways which are affected, and depending upon the gene pathway which is affected, their risk for the development for the particular cancer as well as at a particular age, that is different in different pathway. Okay, so the American Gastroenterological Association estimates that the prevalence of Lynch syndrome is around 1 in 440. Okay, and among all the endometrial cancers, 3% of the cancers, endometrial cancers, will be due to Lynch syndrome. Okay, and same is in cases of CA colon also. Now, so these are the total cancers which are seen in patients with Lynch syndrome. So if you see at the top, any cancer risk is around 81%. So any of the cancers they can have, the risk is around 81%. There is a most common, we'll see the endometrial cancer 57%, ovary 17%, and if you see the colon, which is 45%. Okay, so you have endometrium 57%, ovary 17%. So in females, because it is an autosomal dominant condition, there will be risk of transmission to 50%, and both males and females will be getting affected. So in females, endometrial cancer will be most common, and ovarian cancer. But overall in the general population, colon cancer is common, which is around 45%. Okay, and if you see, the rest of the cancers are 7 to 8%. Brain is 5%, stomach is 8%, duodenum is 7%, bladder 8%, ureter and kidney are 7%, then breast is 13%, and sigmoid and rectum is 13%. So if you remember, breast and sigmoid and rectum, they are 17%, ovarian 17%, and endometrium 57%. So breast and sigmoid colon 13%, endometrium 57%, colon 45%. Okay, and if you read below what is written here, in path PMS2, the breast cancer could be as high as 55%. Okay, so I have already mentioned, depending upon the gene pathway which is getting affected, the risk varies. Okay, with PMS2, the breast cancer risk will be as high as 55%, but overall they have quoted as a 13% risk. Okay, now see this particular figure. You can notice in the table they have given the risk of endometrial cancer, and on the left side they have given the gene pathway which is getting affected, and down below they have given the ovarian cancer and the gene pathway. Okay, gene among the gene we have MLH1, MSH2, MSH6 and PMS2. So endometrial cancer at around 40 years of age, there is a less risk for endometrial cancer at 40 years of age, and that is also due to MLH1 and MSH2, which is around 3.1 to 1.5. Okay, but for the same genes MLH1 and MSH2 at 70 years, the risk is 42.7 and 56.7. So high risk due to MLH1 and MSH2 at around 70 years of age. And if you see the MSH6, that risk is same as other cancers, that is MSH2, that is 46.2 at 70 years of age. Okay, so the risk is less at 40 years of age, but it suddenly increases for MSH6 to 46.2. Okay, similarly if you see down below in the ovarian cancer, they have given the risk at 40 years of age and at 70 years of age. Okay, so LS is or Lynch syndrome is not a uniform disorder. The degree of penetrance and disease spectrum and age of cancer onset vary according to the mutated gene. Okay, so actually we should know the genomic diagnosis, then we can predict more. The incidence of endometrial cancer in MSH6 pathogenic variant carriers is as high as that in MLH1 and MSH2 pathogenic variant carriers, and the risk is much higher than in PMS. So this is what we have discussed. MSH6 risk is 46.2, that is equal to MLH1 or MSH2 at around 70 years of age. Okay. Now coming to the colorectal cancer and Lynch syndrome. This will not be asked because most of the questions are related to OBGY, but generally the colorectal cancer is common in these patients. Certain things we should know. One is the colorectal cancer is the most common and lethal cancer seen in Lynch syndrome. So among the female you will have the endometrial cancer, but in general population colorectal cancer is the most common and lethal cancer seen in Lynch syndrome carriers. Risk of developing colorectal cancer depends on the affected gene and the sex of the individual. MLH1 pathogenic variant cumulative lifetime risk is 47% for colorectal cancer, and PMS2 pathogenic variant risk is 14%. PMS risk is always lesser. Okay. The Lynch syndrome associated colorectal cancer has an earlier age of onset with a crude median age. Diagnosis is around 52 years versus 69 years in sporadic cases. So this colorectal cancer is seen at an early age around 52 years. Okay, while sporadic is seen at 69 years. Women have a lower penetrance than men, which means their risk of colorectal cancer is less, but still it is higher than the general population. And for these patients, what is indicated, at least 6 monthly colonoscopic colorectal surveillance is the main strategy for surveillance. Okay, but even the subsequent slide will mention the colonoscopy is not that easy in these patients. The pathophysiology of Lynch syndrome associated with colorectal carcinoma makes colonoscopic detection difficult because tumors arise from the flat adenomas and they are hard to detect. So these are the flat adenomas. Even if you carry out the colonoscopy, it requires expertise for the diagnosis. Okay. Then the cancers have a propensity to the right side of the colon rather than the rectum and the sigmoid. So if it is a left-sided lesion, it is easy to pick up, while the right-sided, they are more common on the right-sided. Okay, and synchronous and metasynchronous cancers are common. So more extensive surgery with iliosigmoidal or iliorectal anastomosis is often required. So these patients also require extensive surgery. So this is what is the issues with the colorectal cancer. Now coming to the risk reducing strategies in women with Lynch syndrome. Here most of the things are very, very important. Okay, so women with Lynch syndrome, when we should see these patients around 25 years. If she is a carrier for Lynch syndrome, we should see this lady around 25 years of age. She should be seen by the gynecologist to learn about the red flag symptoms of cancer and discuss family planning and explore risk reducing strategies. Hysterectomy and bilateral salpingic oophorectomy at around 40 years of age, okay, that is shown to be cost effective strategy. And in premenopausal women, bilateral salpingic oophorectomy at the time of risk reducing hysterectomy will result in surgical menopause. So if we carry out TH and BSO at around 40 years of age, that will lead to the surgical menopause. That will lead to the vasomotor symptoms, urogenital dryness and atrophy, and also reduced sexual function, emotional liability and cognitive decline. So patients should be counseled accordingly, and they should be counseled for the benefits of estrogen replacement therapy provided through the transdermal application. Okay, so ERT, estrogen replacement therapy through transdermal application for good quality of life and the future health. So this is one of the important strategy in these particular women. One is they should be given health education and should be told about the family planning and further risk reducing strategies. Okay, so there is a limited evidence about how lifestyle affects the gynecological cancer in women with Lynch syndrome. Now let us talk about the role of oral contraceptives and all. We know well that the oral contraceptive pill known to reduce the sporadic endometrial and ovarian cancer. So for sporadic endometrial cancer and ovarian cancer, oral contraceptive pill definitely have a role. They also have a role in reducing the BRCA1 and BRCA2 associated ovarian cancer. Okay, so oral contraceptive will reduce the risk of endometrial cancer, ovarian cancer in sporadic cases. Okay, even they will reduce the ovarian cancer which is related to BRCA1 gene and BRCA2 gene. We also know that LNG-IUS reduces the risk of endometrial cancer in general population, but there are no conclusive data to support the use of these interventions in women with Lynch syndrome. So this question can be asked: the OC pills reduce the incidence of endometrial or ovarian cancer in patients with Lynch syndrome? True or false? It is false. It does not have a role in reducing the prevalence of these cancers in cases of Lynch syndrome. The prevailing wisdom is that they probably have the beneficial effect on the gynecological cancer risk. Okay, taking aspirin reduces the risk of all cancer types in Lynch syndrome carriers. Aspirin appears to reduce the endometrial cancer risk in obese women with Lynch syndrome compared to the non-obese women. So these patients should be started on the aspirin therapy to reduce the overall cancer risk, and it is more protective in obese individual for endometrial cancer than the non-obese women. Okay, endometrial cancer survival rates in women with Lynch syndrome are extremely good. 10-year survival is in the range of 90% or more. So lifestyle factors may also affect the cancer risk in Lynch syndrome carriers. Smoking, alcohol, increased BMI increase the risk of colorectal cancer in individuals with Lynch syndrome. However, few studies specifically explored the effect of lifestyle choices on gynecological cancer risk. So if you talk about the lifestyle, what is the role of lifestyle in Lynch syndrome? There is a limited role. Okay, but lifestyle definitely has got a role in general about the oncogenesis, because most of the cancers, not only the Lynch syndrome, but there are other cancers which are also lifestyle related. So that is why we need to advise the lifestyle changes to these patients. So despite a lack of robust evidence, it would seem sensible for women with Lynch syndrome to eat healthy diet, maintain a healthy weight, take regular exercise, avoid smoking cigarettes, and either abstain from or reduce alcohol intake to a moderate level. So I hope you have understood this paragraph. So there is a lack of robust evidence, but still it is sensible to advise them to have a healthy diet and healthy lifestyle. Okay. So now let's see this particular table. Okay, so what are the methods of surveillance which are used in the Lynch syndrome patients for gynecological cancer? For endometrial cancer, we can use pelvic ultrasound, we can use endometrial biopsy, and third is a outpatient hysteroscopy directed biopsy. Okay, so pelvic ultrasound, what is the benefit? It is cheap, widely available, acceptable to women, minimal complication, and the sensitivity is around 15 to 100% and specificity is around 55 to 100. Okay, then endometrial biopsy, it is a OPD procedure. Tissue diagnosis is obtained. While in pelvic ultrasound, you do not have a tissue diagnosis. Okay, and endometrial biopsy is widely accessible. Sensitivity and specificity, sensitivity is around 80 to 100% and specificity is around 60 to 100. Then next strategy for endometrial cancer screening, what we have is outpatient hysteroscopy plus or minus biopsy. Okay, so carry out outpatient hysteroscopy and take the biopsy. Again, this is outpatient procedure. You get a tissue diagnosis, it is widely accessible, and target biopsy. Okay, and sensitivity is around 90 to 100% and specificity also same. For ovarian cancer, same. Pelvic ultrasound you have, then CA125 levels, and you have combined pelvic ultrasound and CA125 levels. And sensitivity and specificity will be highest with the third option, that is CA125 plus pelvic ultrasound. Okay. Now this particular table tells about the role of various risk reducing strategies. So what are the strategies we have seen? One, what we have seen is a hysterectomy plus minus bilateral salpingo-oophorectomy. Okay. Second, we have seen the aspirin. Third is a lifestyle cessation. Lifestyle, that is smoking cessation, reduce weight, increase exercise, etc. And fourth is a hormone based therapy. So what is the role of hysterectomy plus bilateral salpingo-oophorectomy and when it should be advised? So the female LS carrier, Lynch syndrome carrier, those who have completed the family can undergo hysterectomy along with bilateral salpingo-oophorectomy. Okay. Now for path MLH1 and MSH2, it is at 35 years. We should know because sometimes they ask this as a SBA, at what age this bilateral salpingo-oophorectomy is advised. Okay, prophylactic hysterectomy with plus minus bilateral salpingo-oophorectomy is advised. So path MLH1 and MSH2, it is at 35 years. Path MSH6 is 40 years and PMS2, it is late, it is 50 years. I already mentioned for PMS2 risk is less and it is late also. So for PMS2 it is around 50, MSH6 is 40 and MLH1 and MSH2 it is 35. Okay. Then what is the mechanism of action of this? It removes the organs which is prone for the cancer. So one is a hysterectomy, second is a aspirin. So all LS carriers should be advised aspirin. Okay. Then from around 18 years of age, what is the mechanism of action which is not fully understood. Okay. Then third is a lifestyle, that is smoking cessation, etc. That should be advised to all LS carriers. Let's see about the evidence level. Evidence, that is the for hysterectomy there is a retrospective cohort, then for aspirin there is a large international randomized control trial, but for lifestyle there is a limited evidence in LS population, mostly drawn from non Lynch syndrome population and small retrospective cohort data. So we have already discussed this lifestyle has got a limited role, but still it is sensible to advise these patients the lifestyle changes. Okay. Now let us come to the fertility and Lynch syndrome. Lynch syndrome is an autosomal dominant condition, and we know what is the risk of transmission to the next progeny. In autosomal dominant, there is a 50% chance of passing on the defective MMR gene, that is mismatch repair gene, to their children. Okay, so Lynch syndrome is on the list of conditions curated by the HEFA, that is Human Fertilization and Embryology Authority, for which they can access PGT, that is pre-implantation genetic testing. Because it is a genetically related cancer, they can have IVF, they can undergo PGT. Okay, so that this reduces the risk of transmission. Okay, because the MMR pathogenic variant, the embryos which are lacking the MMR pathogenic variant, they will be selected for transfer following the IVF. So it reduces the risk of transmission, but IVF itself is a demanding process, and in many couples affected by Lynch syndrome prefer to conceive naturally, whatever is the risk. Okay. Now, how the Lynch syndrome is diagnosed in for endometrial cancer? The prevalence of Lynch syndrome in women with endometrial and ovarian cancer is around 3% and 1 to 2% respectively. So among all endometrial cancer, around 3% will be due to Lynch syndrome. Among all ovarian cancer, Lynch syndrome will contribute to around 1 to 2%. So there are clinical criteria, that is Amsterdam 2 criteria and revised Bethesda guidelines, which are based on age and family history based prediction tools. So family history and age. So they are taken into account, and there are prediction tools which are designed to target the Lynch syndrome testing in colorectal cancer. Use of these tools in endometrial cancer has been explored in several studies, and the specificity is reported as a 61% and 49% for Amsterdam 2 criteria and revised Bethesda guidelines respectively. There are newer prediction tools, MMR Predict, then 39 MMR Pro 40 and PRE MM5, they have got a better sensitivity. So basically there is a 3% incidence of Lynch syndrome in endometrial cancer, and 1 to 2% of ovarian cancers are due to Lynch syndrome. That much you remember. And there are some uh, prediction tools which are designed. Okay, now the tumor based testing. Tumor based testing does not identify people with Lynch syndrome, it stratifies their risk of the condition. Okay, so the modalities which are available are: one is IHC, that is immunohistochemistry, and second is a microsatellite instability testing. Okay, so IHC and microsatellite instability testing, these are the two modalities for tumor based testing. Okay, in microsatellite instability testing, the tumors are categorized as MSI stable or MSI is low if it is 30% of markers are unstable, and MSI high, that is MSI H, if more than 30% markers are unstable. And this is the category to which the most Lynch syndrome tumor belong. So the patient should be MSI high. MSI high, then these patients are uh, prone for Lynch syndrome. So that is what is the diagnosis. Okay, genomic diagnosis, then somatic as well as germline testing can be performed, and the technique which is used is next generation sequencing, that is NGS. Both somatic as well as germline testing can also be done, but the final testing is a germline testing only. Okay, and what are the targeted treatments in Lynch syndrome associated with gynecological cancer? The PDM, the PD1 checkpoint inhibitor, that is pembrolizumab, is a Ig4 isotype antibody that targets the PD1 receptor expressed by the peripheral lymphocytes. So this drug you can remember, pembrolizumab. Okay, it is a PD1 checkpoint inhibitor. That is one of the proposed drug in patients with Lynch syndrome. Okay, so if you see that the technique for diagnosis, we have discussed two techniques. One is IHC, that is immunohistochemistry testing, and second is a microsatellite instability analysis, that is MIS analysis. Okay, so IHC testing is done for MLH1, MSH2, MSH6 and PMS2. If it is a MLH1 and PMS2, the protein is absent. In that particular case, they carry out MLH1 promoter methylation testing. See the flow chart. The left hand side, IHC for MLH1, MSH2, MSH6 and PMS2. For MLH1 and PMS2 proteins are absent, you go for MLH1 promoter methylation testing. If it is hypermethylated, it is unlikely to be Lynch syndrome. Okay, but if it is normal, MLH1 promoter methylation testing is normal, then you have to go for germline testing. Similarly, you go to the right hand side, that is microsatellite instability analysis. What we have seen, if it is a microsatellite instability is high, in that particular case, these patients are at risk of development of the Lynch syndrome. So if MS microsatellite instability is H, that is high, then you carry out MLH1 promoter methylation testing. If it is normal, then you go for germline testing. Most probably there is an arrow which is missing there. If it is hypermethylated, then it is unlikely to be LS. So just remember few things, that IHC and MIS, that is micro instability analysis, these are the techniques which are used in these patients. Okay, so that finishes the topic of Lynch syndrome. Thank you.